Okay, welcome. Welcome to the very interesting presentation about TULSA, which is a new minimally invasive device for image-guided treatment options for localized prostate cancer. Patients with localized prostate cancer can be divided in three groups. The first group is a low-risk group with grade group 1 or Gleason 6. Most of these patients opt for active surveillance, so active surveilling the disease. The other two groups are intermediate and high-risk group prostate cancers. Those patients, if they can undergo treatment, they opt for radical prostatectomy or whole gland radiation therapy. However, those two treatment options are in general whole gland treatments. And with whole gland treatments, you always have the problem of the side effects in terms of incontinence and erectile dysfunction. So there's an unmet need to improve these treatment options. And there's also an opportunity for less invasive and functional preserving therapies. And if we provide these kind of therapies, it also allows us and gives us the possibility for additional intervention if needed. The pathway we think of modern prostate cancer consists of the diagnosis, urology diagnosis by PSA and digital examination. And if there is a clinical suspicion of prostate cancer, the patient is sent to the radiology department to undergo an MPMRI of the prostate. Reading, of course, is being performed. And if there's a PIRATE 4 or 5 lesion, then the patient goes for an in-bore or target biopsy by using fusion to confirm the MRI finding. If the MRI findings are positive and also proven by histology, if it's a Gleason 7 cancer or a Gleason 6, patients can go for an MRI-guided therapy like the TULSA treatment. After treatment, patients still will go for monitoring, the standard urological follow-up by PSA, but also by radiological follow-up by using MPMRI of the prostate to check whether there are no other lesions popping up. The TULSA-PRO device is designed for incision-free precise ablation. And it's a new technology which uses high-intensity thermal ultrasound to destroy tissue, in this case prostate tissue, by treating the prescribed boundary to an ablative temperature of 55 degrees Celsius. The procedure itself takes place entirely in an MRI suite with a patient under general anesthesia or regional block. The urologist inserts a rigid transurethral ultrasound catheter into the prostate, and that's connected and secured with an MRI compatible robot that provides linear and rotational motion of the device within the prostatic urethra during treatment and planning. The catheter itself has 10 elements, separate elements, each which are independently controlled for acoustic power and frequency. In the rectum, there's an endorectal cooling device which is inserted, and this cooling device is placed because you want to have no thermal damage to the rectal wall. This is how it looks in real practice. So the device is inserted in the urethra. During the ablation, real-time thermometry images are being acquired by the MRI, and these are sent to the TULSA software around every 6 seconds. And these images are processed immediately upon arrival, and the controller in turn calculates the optimal device rotation rate, so of the urethral device, and also the amount of acoustic power and acoustic frequency for all the 10 active ultrasound elements. And this process repeats itself indefinitely until the ablation is being completed. And the control parameters, as mentioned before, are adjusted based on reaching the 55 degrees Celsius temperature at the prescribed boundary. Of course, we want to have the shortest possible treatment time, but also we don't want to overshoot into the surrounding structures. The MRI-guided treatment workflow consists of 4 phases. The first phase is the preparation, which is done outside and inside the MRI room. The patient is placed on the MRI-compatible table. Bladder catheter is being inserted. Then the patient is placed in the MRI suite. The devices are being inserted into the urethra and rectum. The patient is placed in the MRI itself. Then the MRI acquisition is being performed. And 3D imaging of the entire prostate is being acquired, and high-resolution T2-weighted imaging through the prostate itself. That's the see and plan phase. It's a collaboration between the urologist and the radiologist. It allows also for precise treatment planning and contouring of the entire prostate. The third phase is the ablation with the temperature control, as mentioned before, using the automated and robotically driven adaptive therapy delivery of driving the urethral device. And the fourth part, if we have done the ablation, confirmation of the ablation itself is being performed by using a contrast-enhanced MRI, which can be compared with the temperature maps which are being acquired during the ablation. The TULSA device itself has several components which are found in the MRI suite, inside the MRI room, as well as in the control room. The robotic arm and computer hardware are in the MRI room. The NC system is together with the surgeon control console outside the MRI room, but next to the control of the MRI scanner. And the consumables, disposables, are the ultrasound applicator and the anaerobic cooling device, which are only used once. So if we look at the treatment workflow timing, again, several phases, as mentioned before. It's important to understand that it's a collaboration between urologists and radiologists regarding the treatment planning and ablation, but also good communication with the anesthesiologist is very important, because during the ablation, the patient shouldn't move, because this will result in inadequate treatment of the prostate. So good communication between the 3 specialists, but also with the MRI technician and nurse is very important to have optimal treatment for the patient. If we look at the MRI room time in total for a target treatment ranges from 95 to 125 minutes, and for whole gland or BPH treatment up to 135 minutes per patient. The TAC trial, the TULSA-PRO ablation clinical trial, is the most extensive and up-to-date clinical data trial so far. This is a multi-center prospective single-arm clinical trial, which were patients with low to intermediate risk prostate cancer with biopsy-proven prostate cancer. The whole gland treatment was being performed. 67% of the patients had intermediate risk, and 33% had low risk prostate cancer. PSA had to be less than 15 nanogram per ml, Gleason less than 7, 3+4, and age was restricted between 45 and 80 years. And the primary endpoint after 12 months was safety, and we looked at frequency and severity of adverse events. We also looked at efficacy with a PSA reduction of more than 75% in more than 50% of the patients. And the secondary endpoint was up to 5 years, 12 months volume reduction and biopsy, and 12 months MPMRI, which were read in the central radiology lab. We also looked at quality of life using the EPIC, IEF, and IPSS questionnaires. If you look at the baseline histology, around 64% had Gleason grade 2, 33% had a Gleason grade 1. If we look at the ablation efficacy, the primary endpoint of more than 75% PSA reduction in more than 50% of the patients was reached. 95% median PSA reduction was being obtained. PSA nadir of 0.34, ranging from 0.12 to 0.56 was being noted. and more than 75% reduction was seen in 96% of the patients. If you look at the histology, so biopsy after 12 months using a Tango biopsy, 65% of the men had no evidence of cancer, 14% had low volume grade group 1, and among the 68 men with grade group 2, 79% were free of grade group 2 at 12 months. Similarly, 77% men with high volume grade group 1 at baseline had either no cancer or low volume grade group 1 at 12 months. So if you look at the overall histological improvement, occurred in 75 to 80% of the men across all risk groups. If you look at the MRI at 12 months, MPMRI with central review, 90% had a prostate volume reduction, and the NPV was more than 90%. If we look at the safety profile and quality of life, we didn't observe any intraoperative complications, no rectal injury or no rectal fistula, so we didn't observe any grade 4 adverse events. A total of 12 grade 3 adverse events occurred in 8% of the men of the total patient population, which included genitourinary infection, uterine structure, urinary retention, and urethral calculus and pain, and urinoma, which all resolved by 12 months visit. If we look at the erectile function and compare it with the baseline, around 75% had erection sufficient for penetration at 1 year, and this increased up to 83% in those patients with a 2-year follow-up, indicating a continued recovery. Moderate urinary incontinence, grade 2, so patient needed pads, was reported by 3 patients, so 3%, with no new incontinence in 2 years. So if you look at the summary of the TEC trial and compare this with the literature review of other trials within this context, the TEC trial had 65% negative biopsy after 12 months, which is almost comparable with other techniques. If you look at the clinical significant cancer, around 21% seen in this study, which is comparable with also again with prostatectomy and radiation therapy, and to a lesser extent to HIFU, which had a higher clinical significant yield after 12 months. If we look at quality of life, erectile dysfunction, urinary incontinence, they far performed better compared to prostatectomy and HIFU, but also with radiation therapy. GI toxicity, we didn't observe any GI toxicity, whereas with prostatectomy, radiation, or HIFU, this ranges from 7% to 25%. So the TEC trial focused on whole gland treatments. The trend is going to more personalized medicine, so to perform a targeted or focal treatment. So routine long-term data will be collected under the TULSA registry. Patients with very recurrent disease, the group in Finland has extensive experience in this field, and they also submitted a paper for publication. BPH treatment using a TULSA approach is quite appealing, but also targeted treatment of LUTS is also combined, is submitted for publication. This is an example case from the TEC trial as a case study. This is a 68-year-old male, PSA of 7, prostate volume of 52 cc, a Part 5 lesion in the peripheral zone on the left side. Target biopsy revealed 3+4 cancer. 2 out of 2 were positive, with a total cancer length of 12 millimeters. So this is an example of this patient who underwent a whole gland treatment. In yellow, we contoured the prostate, and this is also the ablation area. The T-map shows the temperature, maximum temperature, which was being obtained during the ablation. The T1 weighted with contrast enhanced MRI shows no contrast uptake within the ablation zone, which almost one-on-one correlates with the T-map maximum. A total of 42 minutes was being used to do a whole gland treatment in this patient. So follow-up of this patient showed the PSA decreased from 7.3 to 0.22 after 1 month and 0.4 nanogram per ml at 1 year. Patient had a negative NPMRI and a 12-core biopsy at 12 months. He had no urinary incontinence, no change in epic bowel habit score. The International Prostate Scoring System improved from 14 to 8. The quality of life improved from mixed to delighted, and there was no change in erectile function. So this device can also be used instead of whole gland treatment to do a partial gland ablation, so focal treatment using TULSA. As mentioned before, it enables a treatment personalization with potentially better safety profile. So if it can prevent hitting the nerve bone on the contralateral side, the patient can still maintain erectile function. And it also can be used to treat the index lesion. And this is, for example, a treat and resect study, which shows an ablation in the right peripheral zone and transition zone. And after prostatectomy, which is correlated nicely with whole mount section histopathology, shows that the entire tumor is being taken out using thermal ablation. This is another example of a targeted treatment. This is a 6-year-old male with a PSA15. Biopsy showed a grade group 2, prior 4 lesion in the left peripheral zone. The T2-weighted imaging shows a lesion up to the capsule of the prostate, and the high B value confirms this finding on the T2-weighted imaging. Target biopsies were being performed and were concordant with the NPMRI. In this patient, we did a target ablation, an hemiablation of the left side. Again, the T maximum map shows an ablation, and in general, we take maximum 3 sweeps of this prostate half, and in total, I think it took around 20 minutes to perform 2 sweeps at that left side. The T1 weighted after contrast shows also no contrast uptake in the ablation zone. PSA after 2 is still stable, NPMRI was negative, and there was no change in the urinary, sexual, or bowel function. An example of a BPH and prostate cancer study. So this is a prospective BPH pilot study from Turku, Finland. They have quite some experience in this field. A targeted prostate anterolateral and middle lobes preserving airway ducts ablation was being performed. Ablation of 24 cc in 21 minutes, including a prophylactic ablation of a prior 3 lesion in the right posterior lobe, which can be observed on the T1 with contrast. There's no uptake of contrast anymore in this area. So to conclude, MRI-guided TULSA is a very promising technique. It also provides real-time MRI thermal dosimetry and control for precise thermal ablation of prostate tissue. It's highly flexible. You cannot only do, for example, whole gland treatment, but because it's customizable, you can also perform partial ablation or apply it in patients with local recurrence after radiotherapy, or even for BPH nodules. We're also having ongoing studies to support clinical evidence for this kind of procedures. And in a clinical routine, and if you have experience with this kind of procedures, you can do up to 4 procedures per treatment day in various hospitals and imaging centers. And this is done in the USA, Europe, and Asia. Thank you for your attention.